about rapid sequence intubation. And this week, we're kind of moving on to what do we do if we feel that somebody's going to have a difficult airway? What other adjuncts do we have? How else will we be able to get the patient intubated, get them an airway so that we can adequately oxygenate them? So the first part, we're just going to say, what are predictors of a difficult airway? How are we going to say if somebody is a challenging airway? Or there's things we can identify? And a lot of it is just looking at your patients. In anesthesia, and when people aren't doing an emergent airway, we do really use something like the Malin potty. The Malin potty is basically, it's down below, and it's going to be the assessment of their airway. A Malin potty 1, you'll be able to see kind of everything. You can see down in the picture. 2, you can see a little bit less of the epiglottis and still part of the opening in the oropharyngeal space. 3, can't see much. And then 4, you can't see anything. A Malin potty 4 predicts a very high degree of difficulty, so it is important to know that. Unfortunately, in our patients, a lot of times we don't have the ability to do these tests because they are hypoxic, they're agitated, they're on a BiPAP already, they have a non-rebreather or other type of mask on. So we really have to rely on doing an external evaluation. Looking if somebody is obese, they have a high likelihood of difficult airway. Everything is kind of compressed upward. They often have a shorter neck because of how much fat is there. They closer. A lot of these obese people will inherently have Malin potty 4s because of the extra tissue. So that's the first thing. But those other external signs that we know might give us a hard airway would be trauma. If somebody has any type of C-spine injury and their neck is immobilized, so they're in a C-collar, you can assume it's going to be a little bit harder of an airway. Decreased neck mobility. And again, you may not be able to assess how mobile they are, if they can extend their head backwards and forwards like they would do in anesthesia in a non-emergent setting. But you can assume that somebody that's much older or has kyphosis where their neck is kind of sticking forward, they're probably not going to have a lot of ability to extend their neck, and there'll be a difficult airway. Somebody has really large dentition or teeth, or if their teeth are absent, if they have a big tongue for whatever reason, whether that's why you're intubating them or just anatomically, that short neck, a small mandible, and by that, that's the people that kind of have that jaw that looks like it's in the back and it's behind their mouth, and it just doesn't look like it's good and pronounced airway. And then anybody that has an airway obstruction, and a lot of times that's why you're intubating them, but just know these are going to be tough airways, very difficult. So somebody with anaphylaxis, angioedema, epiglottitis, retropharyngeal abscess, anything that you anticipate there's going to be something going on in their mouth that would cause swelling, a burn as well. Anyone with history of surgery, they've had radiation treatment, and that's if they've had a cancer, so throat cancer or mouth cancer, the radiation can cause a lot of scar tissue that not only decreases the size of the airway that you're dealing with, but it can also make it really tough to pass tubes because there's not a lot of elasticity left. It really hardens everything. If you are having a tough time ventilating the patient with a bag, so you can't bag them very well, you're meeting resistance every time you're trying to bag them, or you can't hold the mask, seal it to their face very well, that is actually also a predictor of a difficult airway. And then if they've been intubated many times, because that can cause scar tissue, and especially if it was done recently. So big thing, just every airway you do, look and assess. And if you've done airways or you do an intubation and it doesn't go exactly how you planned, it's good to assess why and put that in your knowledge bank and understand, why was that difficult, that airway difficult? What was it about that patient? What did I do? And that way in the future, you can be better prepared, because being prepared for intubation, we talked about that last time, is the key to success. And so being prepared for a difficult airway is going to give you a much higher chance of success than being unprepared and being, floundering and not anticipating when an airway is going to be tough. That being said, for whatever reason, somebody could be anatomically normal and you can get in there and it could be really challenging. So kind of approach every airway like it may be difficult, but give extra attention to the ones that kind of meet these things. When you've decided, okay, well, this may be an extra difficult airway, what would you do different? So we're still going to go through our intubation checklist. We're going to have everything that we normally would, but we might try to get some extra resources. First and foremost, especially like for myself, I'm going to get all available staff and support that I can, and, not just for better visualization of the airway structures. As you go in, you can just see things a little bit more clearly. For me, I feel like I always get a better view of the vocal cords, and I can more easily pass the tube. Studies have shown that this is the case, and in most studies, when they compare video laryngoscopy to direct laryngoscopy, so using just with laryngoscopy. So, not just anecdotally that you are teaching other people intubations. It's really nice to have video laryngoscopy because other people can see what you're doing. If you're doing a direct, but you can share the screen and other people look. This also helps ensure, you can get a second set of eyes to look and say, yeah, I saw it pass through cords, or, kind of gets everybody in the room on the same page. This is great patients that have seed collars on because you don't need to, or you think they're going to decrease neck mobility because you don't need to lift up quite as aggressively. You can kind of finesse and see without moving the neck a lot. The downside for these can be that they're more expensive. So not every department is going to have the resources to be able to afford this. So that's a downside, obviously. Another downside is, it's a machine and machines can fail. So if there's a battery or light malfunction, the screen isn't working, the proper uptake has been taken, those things. Lot of swelling in the mouth, something where you really need to visualize, and visualization is key, or you really only have a small amount of space to get through. This is a great tool because you see the scope is very small. So you can, yeah. Do you have a question, Hempa? Okay. Well, I see somebody trying to talk. I think if you do, you can ask in the chat and I will answer. But these are great for a lot of things like that. Traditionally, and then I will use these if you're going to do an awake intubation, which we'll talk about. It's really, really good to use a fiber optic laryngoscope because it's going to cause a little less trauma. You can be very fine-tuned with these. As you can see, you can look throughout the whole airway as you're passing the scope and see and get a good view. These were traditionally very cost prohibitive, so they weren't really held like in emergency departments, and that's even in the United States where I trained. We didn't have, we wanted it, we had to call anesthesia. But they're actually devising ways to make these a little bit cheaper or more affordable. I'm just going to mute that. They're finding ways to make these actually a little bit more affordable. And like, for instance, GlideScope, which was one of the fiber optic laryngoscopes that you saw on the other page, they do have an attachment now for a disposable laryngoscope. So that makes it a lot more affordable, and it makes it actually something that you can have available to you in the emergency department, which is really nice. And it's something that does require training. It's guiding these cameras can be a little bit tricky. It's not the, you kind of go with the opposite direction. You're controlling the camera with your thumb. There's a knob on the top of the camera that controls the downside of the camera, and then allows you to pass through. This is really good tool though if you are able to get it. It can help with visualization, diagnosis, and then intubation as well. But it's a luxury, that's for sure, even here. And so next would be kind of a delayed sequence intubation. Now, the primary indication for delayed sequence intubation is if you need to adequately pre-oxygenate a patient that's going to need intubation that you are not able to with just a regular RSI before you've given any medications. That could be somebody that's at high risk for becoming hypoxic during rapid sequence intubation. As an example, a person I might do this in is, say, an asthmatic patient that's really kind of agitated, anxious because they can't breathe well. So they're breathing 35, 40 breaths a minute. They're kind of pushing the mask away. They don't want anything near their face because they're anxious, can't breathe, and it's giving them a lot of anxiety. So you're not able to get them oxygen and they start desaturating, their oxygen's dropping. It's 89, 88, 87%. And you are worried that since it's already dropping, if you were to say push RSI medications, so you push medications rapidly and intubate them without that proper oxygenation, their oxygen might drop down rapidly into the 70s and 60s and even lower. This would be a perfect patient to do delayed sequence intubation on. Another patient may be one where, say, you want to get in, they're bleeding, they have a GI bleed, and you know they need intubated because they're just bleeding so much, but you can't put a mask on them while they're bleeding so much because they're gonna aspirate. So what you might do is give the medication, put in an NG tube to get some of that blood to stop and suction out their mouth, and then pre-oxygenate them and then intubate them. Those are just two examples, and other cases might arise. So the procedure itself, what you would do is you would get the patient and everybody positioned and ready, like you're going to do a traditional rapid sequence intubation. Most likely in these patients, you're going to need stuff for difficult airway because you've already kind of bypassed just a normal airway if you're getting to this point. Going to kind of raise the head of the bed, get them in the position of most comfort for them. I exclusively use ketamine for this, and there may be other doctors that use different medications, but this is really just the best drug for this if you're going to use it or do a delayed sequence. But I would give ketamine 1 milligram per kilogram. And that's because with ketamine, you still have some respiratory drive. You can still talk the patient through taking deep breaths, relatively low side effect profile. So it's a good drug for this. So you would give your ketamine at 1 milligram per kilogram. And then once that kicks in, with the hope that they're less anxious, kind of out of it, you can still talk to them. They are still breathing, but they're not fighting. They're not anxious. And this will allow you to then pre-oxygenate the patient. So if you need to, you're putting that NG tube suctioning out, or you're just going right for putting the nasal cannula on them, putting a BiPAP on them, putting a non-rebreather on them, doing whatever you need to get them pre-oxygenated for the actual intubation. Usually they're going to need to be on oxygen for at least 3 minutes, and that's to make sure that your oxygen saturation is as high as it can be, goal at least 95, 98%, and also to flush some of that nitrogen, which will decrease the likelihood of your oxygen dropping during the procedure. Once you've waited that time, you think the patient is ready, then you're going to go through like a normal RSI. Sometimes you may need to, 3 minutes, the ketamine should still have effect, but you may wish to give a little additional ketamine at that point, or some other sedative drug. So you could give the ketamine, and then also at that time you can give the paralytic to help with success for intubation. So you would give your paralytic, and then you'd intubate the patient, and then from that point on, just treat them as you would. And the next would be an awake intubation. So this is even taking it farther than the delayed sequence. An awake intubation, relatively few indications in the emergency department for an awake intubation. The patient, you really have to have a high suspicion for a very difficult airway. And this may be somebody, it's usually somebody with a significant amount of swelling. So a case or an example, I've only done this one time, and it was when a patient had epiglottitis, so severe swelling of their epiglottis. It was so swollen that we were worried that if we were to lay them back, so in the normal position for an intubation, like lie them completely on their back, that the epiglottis would close the airway and we wouldn't be able to pass the tube. So that was this example of when it was valuable. The patient has to be the right type of patient. It has to be an airway where you do have a little bit more time. It's not immediate emergent. It's more like an impending airway compromise. So impending airway respiratory failure, where you think there's so much swelling, it's going to close off the airway, and you have a little extra time. And then it has to be a compliant patient. So this is not going to be the patient that's really anxious, really agitated. You're not going to have good success because it takes a lot of patient cooperation. So if you do choose to do this, and if you don't do it often, you should definitely get anesthesia involved if you can. You know, this is something they do. It's in their wheelhouse. And if you're doing an awake intubation and you can, get anesthesia and have them help you with it. The procedure itself is you're typically going to give glycopurate or pyrrolate or atropine. And the point of that is to dry out secretions. If you can, give that at least 15 minutes before you start. It takes time to take effect. And you're going to also give them ondansetron, Zofran, or another nausea medicine to prevent nausea or vomiting during this procedure. You're going to dry out the mouth, get it as dry as you can, use a gauze pad, suction, and that's just so that there's no extra moisture and the medications you give will be better absorbed. You can administer 4% nebulized lidocaine, so put 4% lidocaine solution into a nebulizer and nebulize that into the mouth. You can also just spray atomized lidocaine directly into the back of the mouth if you don't have a nebulizer, you can't for some reason. And then you can have the patient gargle lidocaine. Just make sure, and you can even test them before you move on and test them, with a tongue depressor, making sure that you've kind of suppressed that gag and cough reflex. And then, once that happens, because during that time with the oxygen, and it's one nice thing if you nebulize them, they're getting oxygen at the same time. But if you're not doing it that way, then they don't have oxygen. So make sure you then pre-oxygenate the patient well when they have enough oxygen. These aren't typically the patients, they're not going to have an oxygen problem. They're not going to be hypoxic. They're going to be people that have so much oral swelling, or it's more of a facial oral situation. Then so you're going to position the patient, get them in the best position. And during awake intubations, your patient is usually sitting up with the head of the bed at 30 degrees. And this allows the tongue to come down. Just letting gravity take the tongue down, and then it can allow you to see into the mouth as best as possible. You can use either a fiber optic scope, like we talked about. If you have a fiber optic laryngoscope, you can insert it through the nose to go to the back of the airway. And that kind of just, if you go through the nose, that scope is so small, it kind of just directs itself into the larynx, which is a nice part about that. If you don't have the fiber optic, you can use video laryngoscope. How you would do that is you actually turn the scope and then you would kind of hook it into the mouth like this. And then it hooks in and you can see down and kind of pass the tube in that way. And you can also do it with a nasal airway, which is a little bit more challenging, but you can do it with just the video laryngoscopy. if they're gagging, you might have to pull everything out and give them more ketamine or give them more lidocaine. During this, you can, as even though it's an awake intubation, you can give a small amount of ketamine, like 0.3 milligrams per kilogram, just to kind of make the patient comfortable. Once they're intubated, then they're intubated, and you can sedate them like you normally would. Check your airway, make sure it's in the proper position, and then give them a sedative, because that lidocaine won't last that long. So kind of the final adjunct, and one that we should know as ER doctors what to do and how to do it, would be, and if worse comes to worse and you don't have another option, you have to do a surgical airway, and you would do an emergency cricothyroidotomy. The most important part of a cric is knowing the anatomy. And so that's kind of what's up in that top. The indications for this would be if there's been a traumatic incident that's caused significant oral, facial, throat, deformity, hemorrhage, swelling. If there is upper airway stenosis or a severe congenital malformation where there's something wrong where they don't have access through the mouth. If somebody has severe muscle spasms, so if, say, for an example, somebody had a botulism and they have that clenched jaw, and no matter what you give them, their jaw just won't release, then you may need to do that emergency cric. If somebody has uncontrolled vomiting, hemorrhage, no matter what you do, you can't access or visualize the airway. That clenched teeth, like we talked about. If there's a tumor, so a large tumor in the neck or oropharynx that is unpassable. And remember, tumors are highly vascular, so these are ones where you have to be extra careful. If there's oropharyngeal swelling from something besides trauma, like an angioedema or epiglottitis, some infectious disease process. If there is a foreign body that's obstructing the airway, this might be the case for like a child that's something is in there and you can't get it out. Or you've failed intubation, you failed every other modality, and this is what's next. If you get to this, so the procedure, like I talked about, you have to know the anatomy, and that's kind of the most important thing with it. This is another one where if you're going to do an emergency cric and you have any time and you try to get the person that's in the hospital that has the most experience, it's nice to want to do something, and as an ER doctor, you want to step in and take charge and do it. But if it means, if it's probably better for the patient, the person with the most experience is the one doing the procedure. So you're going to gather everything you need beforehand. Same with every part of intubation. So in this case, you're gathering all the regular intubation. You've had it. It's probably already at your bedside, but your surgical kit, very basic. There are kits available from different companies, but you don't need most of that stuff. What you need, and all you need, is a scalpel, usually an 11-blade scalpel, a bougie, and an endotracheal tube. And the typical size would be a 6-0. Often you don't need other things. You can use, there's a Sellinger technique where there's a wire and you pass the wire and then you put the tube over the wire, like a dilator over the tube, and then the tube, and it's cumbersome. And if you don't do these often, not the thing for us. You're going to position the patient with that neck partially extended. So, even if, and this is one, even if they do have a C collar on, you're going to extend a little bit, because yes, you're risking that C-spine, but this is a patient that's dying and they're going to die. And if risking a little extension is okay in this situation. So you're going to extend the head and the neck so that you can visualize and get a good feel for all your anatomy. You're going to try to identify that cricothyroid membrane. So you see it kind of there above. You're going to stabilize the larynx. So that, the larynx, that you can feel it between your thumb and your third finger and you guys can practice this on yourself while palpating the cricothyroid membrane with your index finger. So once you have that and you have it in your hand, then you're going to make a large vertical incision through the skin. You're going to palpate the membrane, and once you'll be able to feel it better once the skin and kind of other tissues out of the way. And you're going to make a horizontal incision through the membrane. The horizontal incision doesn't have to be huge. You don't want it to be too big, actually, because if it is too large, then you're going to have too much. You're going to end up having an air leak, and there'll be air around the tube, and that could inhibit your ability to oxygenate. Then you're going to pass the bougie. Usually you can, if you're using your hands, you can have somebody feel below. You can pass the bougie and they should be able to feel it going through the larynx if it's in the proper position. Pass that through into the trachea. Then over top of the bougie, you're going to load that 6-0 endotracheal tube and kind of push it down till it's in proper position. You don't need to pass the balloon much. So once you kind of enter the skin, right when the balloon is right past the incision, then that's about as far as it needs to go. You're going to inflate the balloon and then attach an end tidal or capnography and listen to breath sounds to make sure you're in the proper position. So yeah, if you look at, I just want to show you the anatomy one more time, because that's like the biggest thing you can do. The procedure itself, you just have to practice on dummies. If you ever get the chance to see it or participate in it, it's a really just one that they don't come around that often. And so if you get involved, see what it is, try to feel the anatomy if you can. And yeah, just remember you're going to be below the thyroid cartilage, but above the thyroid gland, which is way down lower. So below the thyroid cartilage and then above the cricoid cartilage. So kind of between those two. Yeah. So now is the questions, but I'd love to, if anybody has any questions or comments before we get started, then please let me know. So yeah, the questions, if you guys want, the best thing is just, we'll read the question and we'll go the answer, and you guys can, answer in the chat. And this will allow us all to kind of give our responses, and then I'll look and see. So patient requires endotracheal intubation for respiratory failure. Which of the following is the strongest predictor of a difficult intubation? A, absence of teeth. B, elderly. C, Mallampati, class 4 score. Or D, the presence of a beard. Okay, I just have to stop the sharing for 1 second so I can look at the chats. Oh, good job, everybody. Everybody got that one. It's great. Yeah, Mallampati class score, and that's what we were talking about. So that is, of all of these ones provided, the absence of teeth, elderly, presence of beard, a Mallampati class 4 score is the highest indicator for a difficult airway. And remember, it might be challenging if you can, though, and your patient has any ability, you're intubating them for, anything where it would allow you to. It is a really good thing to check. Have them open their mouth really wide, see what you can see. If you can't see anything, just know that this patient is going to be a tough intubation, and that their Mallampati, they can have a class 4 from a lot of reasons. So a large tongue, obesity, trauma, oral swelling. So all those things that we're looking for externally can cause this Mallampati class 4 score. And we know those all lead to hard airways. Yeah, next one. So, which of the following is the most appropriate location for tube insertion in a cricothyroidotomy? A, between the thyroid cartilage and hyoid bone. B, inferior to the cricoid cartilage. C, inferior to the thyroid gland. So that's gland. Make sure you see that part. And then D, superior to the cricoid cartilage. So we got a lot of A's on that one. So that one, it says between the thyroid cartilage and the hyoid bone. So I here's some anatomy and we'll look at it again. So you see the hyoid bone is much higher. So the hyoid bone is way up high. You can feel it. It's going to be kind of just under the jaw, and it helps to, it is the bone that these cartilages insert themselves into. So it is the cartilage that inserts the thyroid cartilage. So the actual location is superior to the cricoid cartilage. So you can see in that you're going above that cricoid cartilage, between the thyroid cartilage and the cricoid cartilage. And so I like this anatomy picture here that's really showing you exactly where you're going to go. So you can kind of see this anatomy, and there's two different types. One is a little more of a depiction, and I wanted that one so you could see where the thyroid gland is. You want to stay as far away from the thyroid gland as you can, because it's very vascular and it will bleed quite a bit. So you can feel in yourself and feel kind of where that's going to be. That if you're on men, it's easy to orient yourself to. You see there's the laryngeal prominence where you'll feel, which is your Adam's apple. So the big thing that sticks out. Women have kind of a more subtle one. But once you find that, just below that is going to be your thyroid cartilage. And below that's where you're going to want to go in your cricothyroid membrane. But yes, this is it's challenging because it's not something we do, and it's anatomy that can be difficult to remember, figure out, and visualize. So next one, a man who weighs 120 kilograms presents to the ED after being injured in a tire explosion. His Glasgow Coma Scale score on arrival is 3, with an oxygen saturation of 73% on room air. He has obvious facial trauma with blood in his mouth and nose. Bag mask ventilation is provided with the assistance of an oropharyngeal airway in place, and his oxygen saturation improves to 92%. He is given etomidate and rocuronium for rapid sequence intubation. During the laryngoscopy attempt, what the cupping? So A, anterior glottis. B, tongue. C, no T body habits. Good. Yes, most of you guys got this one. So D. So obese body habitus. So that's excellent. It's going to cause that kind of obstruction. So they're they have basically a pseudo obstruction. So it's going to make it one challenging. So a lot of times it's going to be a challenging airway. You might not get it on the first pass. That can contribute to it being difficult airway. You are also likely to have a quick desaturation. So your oxygen isn't going to stay above 90% that long. And then there's various physiological and anatomical reasons for that. You have to remember that there's just a lot of extra tissue. So their lung capacity is smaller relative to their body size. So they're trying to perfuse more areas. So when you take out that respiratory drive, they don't have as much residual. So they're going to desaturate more quickly. There's also compression of airway. So when they're lying flat in that intubation process, there's going to, that while they're lying flat, that's an extra position where you're going to have that tissue pushing the diaphragm upwards and decreasing how much lung you have and the ability to kind of oxygenate. Let me just make sure on this chat. Yeah, exactly. And you're right. This case would be could be somebody for that sitting position for intubation. That's definitely true with intubation. The one thing that may make it tough in this particular, like just this case, is that he does have obvious facial trauma in his mouth and nose. So, it'd make me wonder if maybe he has a cervical spine injury. So we kind of have to treat him like he has a cervical spine injury with that history of trauma. And so it's tough to get somebody sitting up in that case. But if you thought maybe it was just isolated to face and even their neck and not their lower body, you still could do that. You could have them sitting up. So yeah, in obese patients, that's a really good point. And you can do, if you're really worried in just an obese patient, that's a good point. We didn't specifically talk about it, but with obesity, even if it's a respiratory issue, you could do RSI with the head of the bed up slightly and go with more of a frontwards approach. So you would do a traditional RSI, you would give your sedative and your paralytic, but instead of having the patient lie flat, you have them up 30 degrees. That gives you, that way gravity is helping pull that tissue down as well as the tongue. And you come from the front, you kind of hook the video laryngoscopy or the direct laryngoscope in the mouth. And then you could pass the tube that way. And it's basically using gravity to help you. So it's a really good way to do that. Actually, it's a good point. So next question. This one's really hard for every, and I understand you guys don't see too many kids, but a 3-month-old boy presents to the emergency department after being ejected from a motor vehicle during a collision. The patient is cyanotic and unresponsive on arrival with an oxygen saturation of 82% and heart rate of 140 beats per minute. The only obvious injuries are substantial facial injuries with full thickness lacerations to the cheek, tongue, including an open mandibular and nasal bone fracture, preventing effective bag mask ventilation. You are unable to visualize the airway during direct laryngoscopy due to bleeding and loss of facial structure. The patient's oxygen saturation drops to 62% and heart rate to 40%. A laryngeal mask airway is ineffective. Which of the following is the most appropriate next step to treat this patient? A, cricothyroidotomy. B, fiberoptic tracheoscopy. C, indirect laryngoscopy. Or D, a percutaneous needle cricothyroidomy. So looks like everybody kind of went with B on this one, which is totally right. So just remember that you cannot do a cricothyroidotomy on kids. So usually 12, because that anatomy has just not developed where that's where it's possible. So in this case, and I kind of, even knowing, you guys don't see a lot of kids, and this is something I would be terrified on a child. I have never done it or even seen it. But remember, you can use this in adults too. So I didn't explicitly talk about this one because if you're using it, for the most part, it's better just to go with the cricothyroidomy on adults. But if you couldn't, for whatever reason, or this is basically your percutaneous, you're going to still do the same anatomy. You're going to try to find that cricoid membrane. So you're going to find it. You're going to find kind of those structures that we talked about. And you're going to take a larger needle, and usually a 16 gauge needle, or with an angiocath, and you're going to just insert this directly into that space. Once you see kind of air bubbles, so you can do this with the saline filled syringe, and then you withdraw a little bit. And once you see bubbles, you know that you're in the right space, because then that means there's air going into the saline and you're in the airway. And so you're going to keep aspirating, get your bubbles, know you're in the right place, and you're going to withdraw that needle and just leave the angiocath in there. Like I said, this says a 14 gauge. I've also seen you can do this with the 16 gauge, but 14 to 16 gauge. So you're going to leave that in there, withdraw the needle and the syringe, and then you'll have an opening. Then you're going to attach the oxygen directly to that. This is a small amount of oxygen. Remember that resistance is going to be proportional to the diameter of the tube, and the resistance is greatly dependent on the diameter of the tube. So a really small tube like this, you're not going to get very much oxygen in. This can work in kids because they don't need as much oxygen, but in an adult, it's going to be very difficult to adequately oxygenate a patient like this for very long. But if you have done everything, or you're not comfortable, you can do this. And then with kids, this is what you would do if you have no access to the oral airway. And then this is the last one. So which of the following is true of a Miller laryngoscope blade? A, it carries a higher risk of stimulating an airway reflex than a Macintosh. Now, as a reminder, the Miller blade, we kind of talked about this last week. Just wanted to refresh with the difficult airway. The Miller blade is going to be that straight blade. So it's the direct laryngoscopy or a video laryngoscopy. The Miller refers to the laryngoscope, and the Miller is the straight, versus a Macintosh that's more curved. So a Miller would carry a higher, this asking carries a higher risk of stimulating an airway reflex than a Macintosh. B, indirectly lifts the epiglottis to expose the vocal cords. C, is the preferred blade in difficult airway situations such as morbid obesity. Or D, a wide base of blade is helpful in controlling tongue movement. So this one's tough, and I just wanted to, we didn't really explicitly talk about it, and I just wanted to kind of come back to this because you will see the Miller versus Macintosh a lot, and that's in with direct as well as those videos